Thank you. Actually, I would like to have with me Mario Baldassare here, because he is the true leader of the group. So, well, let me say that this was a wonderful experience to have all these different inputs from different professions, different types of knowledge. So we merged the two groups because we thought this would sort of have very common topics. One was on long-term care, the other one was on public health. And so I think we came up with a few keywords from the general discussion. Of course, we had a very intense, very complete discussion, but the keywords are, I would say, first of all, ecological approach, meaning that, you know, if one wants to promote a global policy, both from the economic point of view, but also from the welfare, I would say, population welfare point of view, the ecological approach is relevant. And what is meant by ecological approach is that the whole policy is thought as a unified policy where people are aware that, you know, vaccinating adult population has, as we economists call it, positive externalities on the rest of the community and rest of the family, because you expose risks. You're exposed to risks if you go to a nursing home to visit your relatives there, and they are frail people, and you are not vaccinated yourself. The risk is that you bring with you some, you know, some conditions which would affect the nursing home community. So this ecological approach seems to us very important from the economic point of view, but also from the communication point of view, because making people aware of the fact that if you care about your relatives and if you care about yourself, then the promotion of vaccination in the adult population is good for you and for your relatives and for the community at large. So this was one first keyword, I would say. The second important keyword is coalition, because it's very hard to come up with very general and rules which would be acceptable to everybody. And so one line of thought was, why not come up with a European Union type of directive, right? That would say you have to vaccinate all the population 65 plus or 55 plus. I don't know what the best threshold would be. Now, that would go very hard with some parts of the population and with some parts of the policy making. So coalition seems to us the good way to proceed. And there are already examples of this, maybe in the US, that we could borrow from a little bit. But coalition means putting together all the actors, the scientists, the people who are caretakers, the patients themselves or the population at risk, and policymakers. So the coalition approach seems to us, any industries, of course, yes, any industries. So making all of them work for the same objective. And the general objective is, first of all, making people aware, and secondly is to make sure that those who need it are going to get it. The other issue which came up, which is very important, is data and communication, because people have to be informed about the risks and the costs of not being vaccinated or not vaccinating. And it's very important to give correct information. And this I think is a common common thread of all the things we discussed together. One I found very, very interesting, and maybe Mario would be more specific on this, to identify also the entry points where you can sort of contact people. One obvious entry point for kids we know is schooling. So we know that we can get the data the monitoring, but also the action at the schooling level. So is there an equivalent, if you like, at the older ages? And nursing home and long-term care is obviously one important entry point, but maybe there are more, and maybe, again, as a coalition, we can work on this, identifying and making effective these entry points so that we can be cost effectiveness, because the cost effectiveness issue is always coming up. So we know that we have to convince policymakers that this is possible and cost effective. So if we have in mind some target population, making sure that we can reach them and which are the best channels to get through them. So that's one. I think I would stop here because I think Mario has more to say about this.
Thank you very much, Agar. Now, Professor Mario Papagalle, who don't know him, he is a geriatrician from Sicily. But I think for our program here, what it means, to bring it across outside Venice, he's also the president of the medical branch of IAGG in Europe, so International Association of Gerontology and Geriatrics. So, Mario?
Thanks. No, I just don't have much to add because we have a very broad discussion that we actually very participated, and I have actually really to thank both Stefania and Stefania Maggia, Jean-Pierre Michel, Agar, and Professor Crepaldi to have invited us, because actually in this discussion we had economists, we had geriatricians, we have infectivologists, we had people from industry, we have geriatricians, we have people, GP working in long-term care, and we have people from Claudio Franceschi from biogerontology, and actually show the importance of getting together people from different fields and discussing together in a common ground. And Agar actually told us the importance from the economy point of view of the vaccination, and the long-term care is a subset that's actually very important, because we discussed before about the importance of education, the culture in the population, and as we have seen in these 2 days, that was I really learned a lot. I have really to thank all the people participating, and I don't know if Bo, you want to Bo Johnson that they gave a talk yesterday was actually co-chaired with Agar in the discussion. And discussing of long-term care, long-term it's an important subset, because when we discuss about cost-benefit of vaccination, the long-term care is a subset where definitely the cost-benefit is in favor of vaccination. And we discuss a different long-term care in Europe, and also in USA and in Taiwan, also in the other part of the country. There are a lot of difference in the long-term and home care assistance, but definitely we discuss how we can get compulsory vaccination before getting into the long-term care in nursing home, for example, because definitely they will be cost-effective. Also, we discussed about the data yesterday showed by Professor Giavazzi about the difference of the nursing home in which also the home care, the home workers are vaccinated, and the long-term care, the nursing home where the home workers are not vaccinated. So it's important not only to vaccinate the old people getting into the long-term care, but also the people working into the long-term care, and people also visiting. Actually, I'm curious to know what will be the answer to the questionnaire, in which there are actually 2 questions related to the long-term care. because this is a very important issue, and definitely, as we discussed, it's cost effective because the complication of the in the influenza and pneumonia, for example, for hospitalization, death, it's a burden for this all this sanitary system. So it's also well connected with the economic part. So I think I will stop here, and but I have really to thank all the people who participated in this group, and Bob Johnson.
Thank you very much. Something to add from your side, Bob Johnson? You would like it?
I found it a very valuable discussion.
Okay. Thank you very much, sir. So then we go to the next group. It's the group with geriatric medicine, preventive aspects, and acute medicine. So Stefan would present, yeah.
Thank you. With Dr. Grodzicki, we had folks from Switzerland, Poland, France, Taiwan, and Italy. We had 5 major areas that we discussed. Access, and this is access to the vaccine by the older patient, and potential solutions, whether you do it with a visiting nurse in the US, unlike Europe. We now give vaccines in the pharmacy. So it used to be that they were only given in doctors' offices, but now that the pharmacist can give the vaccine, then the temperature control and a variety of other issues go away. And since there's a pharmacy in every town, in every village, and the patients, even if they're older patients, are already going to the pharmacy, they can get the vaccine there. Another part of access is who pays for it. Does it come out of the patient pocket, or does it come out of insurance, or does it come out of the hospital's pocket, depending on where the patient is? And this is different, sounds like, in different European countries. Second point was harmonization of recommendations. There was a question about, who makes a recommendation for Europe. Like in the US, we have the Advisory Committee on Immunization Practices. And for our physicians, this is a major body where if they say you should do it, physicians are relatively likely to take that advice to heart and follow through. This is not to say that all US physicians believe in vaccines, but the ACIP actually carries a large voice, and there is no similar voice in Europe, and that might be something to aspire to. We talked about how vaccines happen. So when a geriatric patient comes over and over again to a hospital, our example was the hospital in Geneva, then they make a recommendation that they should get a vaccine when they go home, or should they just give it in the hospital? What should be the standard of care? And the suggestion was that vaccines should be mandatory as part of, or should be a guideline, it depends on how strong you wish to do this, in the context of a hospitalization. If it hasn't been given, you automatically give it as part of good care. And as part of an admission to a long-term care facility, so geriatrics overlaps with the prior group, perhaps that as they get admitted to a long-term care setting, that they get brought up to date on vaccines, and that an understanding is made that every year after that they will be maintained up to date, so you don't have to ask permission from the patient or family over and over again, as often the patients, geriatric patients, many of them cannot give permission themselves. A third point was registries. So registries has a deeper meaning, because if you can't count it, do you know if it happened? So who must give the vaccine? Is it the specialist or the GP? So if you send them to a specialist, a cardiologist, for example, and they have a patient with a high-risk condition, does that specialist say it should be the GP that does it, or should it be the specialist, or how do they know? A registry would help solve that kind of a problem. How do you know who gave the vaccine? Challenge. It's a challenge to information systems, because if you don't have electronic records, who's going to keep track of this, and how does a place that runs on paper records, the doctor's office or the long-term care facility, know what's happening out there if they don't have computer systems and other things? So a registry, and a harmonized registry that is within a region or country, the bigger the better, would help also with achieving guidelines and performance measures. If you don't register, you can't count it. If you can't count it, you don't know who's done what, and you don't know which physicians are doing a job, and you don't know which patients haven't been vaccinated. And in the registry also, you could do this, who gets paid to give the vaccine. So you can give credit and incentivize this in a different way. The fourth of 5 bullets is advertising and acceptance. We talked about this sort of knowledge. The prior group said the ecology. So how do you make it part of just normal thing that vaccine is something that you do? And so the example we talked about is this, how do you make it so that it's in every person's knowledge, every patient's knowledge that they should be getting vaccines? That's part of how they do what they do, and how does it evolve? So in the US, how it's been evolving and that we talked about was, because we now give vaccines in pharmacies, vaccines overall have grown somewhat in acceptance, because in every town you see advertisements for the vaccines now, for flu vaccine or whatever else, and suddenly the idea that it's just the doctor's job and somebody else's job to get the vaccine done, it now is starting to increasingly become the patient's job. The extreme of this is in Taiwan. We had a member from Taiwan where their vaccine uptake, for example, for flu vaccine nationally is over 99%. So they have a registry system. They know every patient has a chip, so they know who gets it. And every patient knows they should be going in and asking for vaccines. They're health consumers unlike any I've ever seen, where the average person gets 14 visits per year with their healthcare provider. And in one of those visits, they get to get their vaccine and get up to date. News media and public health announcements were another piece of this advertising and sort of general awareness. A challenge has been resistance from doctors and patients, and from the people in our group, we heard varying degrees of resistance by the providers themselves. It's not my job, would be an example, especially if it was a specialist. Or for patients because of not believing in vaccines and so forth. So how we overcome that again and how you make it part of the general conversation. A fourth item under advertising and acceptance was the idea that people have to give consent for vaccine. Now we assume that when people come in for healthcare that they're giving consent to what we do. And we talked a little bit about how you make consenting in a geriatric patient part of standard of care. And an example we used was that when they, for example, step into a long-term care setting for end-of-life care or long-life care, custodial care, that it is an understanding at the time of admission that they will be getting a vaccine every year, that's part of what you do. And you're not so much asking permission, but you're looking for refusal. So they can say no, but they don't necessarily have to say yes. You follow that? So it's a assent without acceptance necessarily. The idea would be that you would still involve the family and you'd let them know what you're doing, so you're not hiding anything. But if they wish to opt out, the way the construct that we've been proposing in America is when a patient, for example, comes into clinic, you say, we have your vaccine here for you today. The nurse will be giving it to you, and they can say no, thank you. But by saying yes, they begin verbal consent. And it's as if they miss an opportunity as opposed to as if they have a choice. Instead of saying, would you like to have your vaccine today? It sounds like you have a choice and maybe you should say no. But if you say, you're going to miss your opportunity to get your vaccine today, that's a different kind of message and approach. And the last for acceptance was increasing payment for vaccination. It seems it is at the bottom of the list of things that get paid for. And so it's the last thing anybody thinks of, and so how do you incentivize this? And you can incentivize providers. And if you change also who gives the vaccine, for example, in the US with pharmacies, if you make it so other people could collect that same fee, the pharmacies have extra incentive because they may make additional money from selling the vaccine and so forth, so you can get a more efficient way to distribute. The last was advice to policymakers must be anchored in cost effectiveness. So we talked a little bit about studies that come out talking about cost effective, and what's cost effective in the US might not be cost effective in Poland and so forth. So there has to be an understanding about how to translate data from one setting to another, be able to do the math in such a way that you can figure out what's cost effective, not just for health outcomes, but actually dollars, so that the political programs can set the money aside for vaccines. We talked a bit about how how the budgets are set aside. The vaccine budget may be different from the rest of the pharmacy budget, or if it's part of the pharmacy budget, but usually it's separate from the rest of the healthcare budget. So if you have a vaccine that prevents, for example, pneumonia, and maybe it's very effective at preventing pneumonia, but it's very expensive, and therefore they can't buy, say, penicillin, what are they going to spend their money on? And the people who are being given credit for not having so much pneumonia aren't the ones that are spending the money on the vaccine. So this is sort of competing agendas because the budgets don't cover each other across things. Thank you.
Thank you very much. Very impressive and good ideas. I would say exactly what we expected. So thank you very much. So because we just spoke about pharmacies, we have now the group pharmacists. It's Rakesh Patel and Mirko Petrovic. I don't know who of you will present. Yes, please. Come to the floor.
Thank you. Just as a way of introduction, I'm Raj Patel, and I'm president of the PGEU, Pharmacy Group of European Union. It is an association of 34 member states, and within Europe there are 500 million people. Of the 500 million people, 46 million people visit a pharmacy every day. There are 400,000 pharmacists in Europe, at 160,000 pharmacies in Europe. So when we were talking earlier on about accessibility and qualified, I suppose, qualified professional, pharmacy is a prime target. I think we said earlier on, just not by myself, but there are others who said that the world is an imperfect place, that vaccination is not a pure science or an exact science, and I would suggest that our global acceptance of vaccination is somewhat incomplete. So we had a number of questions that we tackled on, and three primary questions. What are the hindrances that actually exist within a community with a view that they will not take a vaccination? One of the biggest issues they have, and like it or not, is skepticism about industry. They all feel that industry, and this is not me saying, this is what is being felt, industry is making too much money, therefore they must have something to hide if they're not telling us what exactly vaccines do. Not true. There's education that needs to be done. There's also skepticism about others apart from doctors or physicians being able to give vaccinations. Again, I think there needs to be education there. There needs to be education in terms of who can and who can't vaccinate, but there needs to be confidence out there. The patient needs to be confident in as soon as they walk into an environment that they're able to perform that task in a very competent manner. So there is the issue about the skepticism. There is also the issue about informed patients. Patients now walk into pharmacies, surgeries, even before they go to surgery, to tell them, well, I've just realized what's on Google, and Google says these things should happen to me. In fact, there are 5 side effects in Google, and I think I've got 3 of them. And 9 out of 10 times, they haven't got any. But it is the informed the patients that really we need to get a hold of, and also the fact that they know what vaccinations are all about, but there is the adverse media that goes on about vaccinations, unfortunately, and that again needs to be tackled in a round way. But in terms of education, I think our group had come to a conclusion to say that education should start very young, not only with educating parents for their children at that age, but also for our professionals, not just pharmacy, nursing, every allied health profession that might be involved in vaccinations. The education should start from the point at which they're in university or even earlier. So that is the point at which I think we need to go about it. In terms of incentivization, what incentives are present there right across the member states for patients to go and be inoculated? Now, the obvious one is whether they have to pay for it or not. In some countries, they have to pay for it. In other countries, they don't. And we see that in the United Kingdom, for example, where I come from, and we in our pharmacies do practice inoculation. So in terms of flu vaccinations, we inoculate our pharmacies. And I'll just give you one example. Over the last 4 years, 4 years ago, every patient that needed flu vaccination had to pay for it. And at that time, we inoculated, that's the whole of the UK, we have 14,000 pharmacies in the UK, inoculated something in the region of between 300,000 and 400,000 patients. The following year, it became part of the NHS, the National Health Service, where there wasn't any payment, but pharmacists and the doctors were looked as equals, and we got paid exactly the same money. We are now talking about a service which is now in the NHS. There were 750,000 patients that actually got inoculated. Last year, which was the second year of this service, 1.2 million people got inoculated, and this year there's anticipation of almost over 2 million patients being inoculated in pharmacies. I am just talking about flu vaccinations. I am not talking about any other vaccinations. Some of the other vaccinations that do carry on within pharmacy are shingles, for argument's sake, for example, and also some travel vaccinations. But there are patient group directives which are signed by doctors in order for pharmacists to actually carry out these processes. So there is that issue about accessibility, and I think we can do that. But accessibility isn't a huge issue. You know, the view is that the doctors will only ask me to come in when it's convenient for them. Well, if you turn that round, I will go in when I'm free into a place to get a vaccination, whether it be nurses, whether it be any allied health profession, or whether it be pharmacy. So, for example, pharmacies are open between 9 a.m. on a Monday morning to Saturday 6 p.m. They can walk in at any time they want and they'll get vaccinated. They don't need to make an appointment. And I will hope that we can extend that to other professions in terms of nurses, etc. So again, that was one of the things that we talked about. But the third thing we talked about was global policies. And global policies, we meant about, you know, how are we going to influence global policy? There is absolutely no point in local groups wanting to inoculate their patients if there is no will from their paymasters or from their national health executives in terms of medicines. So from that perspective, I think it is incumbent on leaders in organizations to actually tackle, lobby, and also educate the governmental organizations where vaccinations are paramount and are prioritized. And we talked about the ICN, we talked about FIP, and we talked about SETMED. You know, these are three organizations which are very active in this process. So there were other policies, and together with this European policy of making sure that you know, we are there, we need to have shared best practice. You know, shared best practice between member organizations, and also bridging gaps where some organization may have done this before, and making sure that the organizations that or the countries that haven't do actually follow on those footsteps. So you know, it is best shared practice, not only in terms of the professionality, but also in terms of including themselves in government fora. And lastly, I would say, you know, learning from others, you know, learning from our peers in other medical standings and also in other member states. This is an issue not with just one profession. I think it's an interprofessional issue, an international issue, a global issue, where I think every profession who is willing, is competent enough to vaccinate should vaccinate, because we're talking about a global patient issue and not just a profession issue. So I think I'll stop there, if I may.
Thank you. Thank you very much, making the bridge from the previous speaker. So now the next group will be nurses and health visitors, another very important professional group in this whole vaccination project, I would say, on a global scale. Clara Frasson and Keita Gavazzi, I don't know who will present.
Nobody, in fact, we were together with pharmacists and what...
Okay, do you want to add something? But please then go to the microphone that people understand you, Keita.
Perhaps just to add something to Raf said, what he said about pharmacists was also said for nurses as another healthcare worker. The thing was to think about how we can extend the role of people to address the problem of the issue of implementation. We have several category of things happen in Estonia, in Italy, in France, in Czech Republic, and it was quite different. But at the end, we said the main thing is to be, as you said, play a role, discuss with somebody. I don't know the word before. I don't hear the word before. GPs and pharmacists said a lot of things with GPs. Discuss a lot before implement. I think the thing in UK, in France, they tried to do it quite with force, and it was horrible. The discussion in between pharmacists and GPs. Now I think it's going better. We have the same thing with nurse. So nurse, we address the things, and for visitors, we had perhaps something. It was at least for flu, a universal, as it has been done in United States, propose a universal vaccination, and perhaps before this, it's to, if we want to have physiotherapists, patients, doctors, GPs, quite well, and with the promotion of vaccination, perhaps we have to educate at school, because tomorrow there will be the doctors, there will be the physiotherapists, and I think we have to think about that very much.
Okay, thank you very much also, Keita Gavazzi. What I got out of this presentation, the last one, I think for policy making, we should also put together opportunities and possibilities in different countries. It started what Stefan Gravenstein said for the United States, and what we heard just now, I can just tell you at the moment, there would be a war in Germany if we would say pharmacists do that. So I think we have to show publicly that there are places where it works. So because I think if we want to have a much better coverage for vaccination, we have to go to the different settings, otherwise we will not succeed. And so I think that is very helpful to really put that as a take-home message of this meeting, to show the how different countries are doing it, and that the other ones should see, you know, it can work. Also what you just said. Very impressive. If I calculated well, every 10th person in Europe sees a pharmacy each day. That's more than people going to restaurants. No? Very impressive as a number. So the next presentation will be about NGOs. It's Gary Groman and Giulielmo Weber who will present. Okay.
So Gary Groman for our NGO group. There are only 4 of us, but it was a bit like having a conference within a conference, I think, which was delightful. So a few highlights, and I'll try not to repeat what others have said, but the first point is that there are limited resources. No matter what kind of global policy you want to have or program in a country, there'll be limited resources, and they'll be of 2 types. One is financial, but the other is also human resources. Having educated human resources that know about vaccines, can educate the vaccinee and so on, administer the vaccine, keep a record of the vaccine and so on, is all important. Oh, sorry, is that better? So ideally we'd like to see a program from infant vaccination through to the older person over 70, and obviously it can be stratified into 6 months to 2, 5 to 10, an adult, and you would be able to highlight all the different vaccines that would be needed, including boosters. and also special vaccines for adults depending on their type of work, like Q fever, for example, might also be important. Some of the issues that you would also need to take into account would be co-infection and morbidities, genetics, environment, socioeconomic issues, immune competence, nutrition, things that we've spoken about at this conference. And one thing that's worth highlighting is that most people that are hospitalised due to infectious diseases are in fact those that are under 2 and over 65. We know that vaccines are a great benefit to children and grandparents, and probably more so in those groups than any others. And the other thing we discussed briefly was the changing role of people in society. The whole of society has changed in the last 40 years in the sense that more people are using childcare, 2 parents are working, there are economic pressures, there's more people, there are greater numbers of people that are living longer, therefore there needs to be more care there. And at the same time, grandparents are also helping their families and looking after children. So the whole of the society is changing in that sense. And of course, there's the whole issue of social media as well that has both a positive and negative effect. We discussed some of the impediments were the attitude of healthcare workers to provide vaccines is actually quite poor and sometimes negative. And there have been a number of studies on that. We know about the anti-vaccine lobby, it's already been mentioned. We know about social media having positive and negative effects. But NGOs could bring a strong voice about vaccines, even though the perception out there by, say, the anti-vaccine lobby is that they are dangerous or they don't work, or they have too many adverse reactions or they're not needed, whatever is said. But independent NGOs could have a strong voice that could bring the right message to the elderly. So education of healthcare groups is important, and we identified particularly GPs, nurses, colleges of medicine, aged care groups. Skepticism has been mentioned, and we discussed that as well. It's a major problem, particularly in healthcare workers and the public. Also, a lack of trust in government and vaccine companies. We did wonder if vaccine clinics might be useful. In some areas of the world, various companies or workplace platforms actually bring nurses with vaccines into the company and have a vaccine day. That might be for flu, it might be for pertussis, it could be for measles. A lack of harmonised schedule was a big item of discussion. So if we want vaccines for life as a campaign, then what we have at the moment around the world is extraordinary variation of what that vaccine schedule might look like. And we thought there should be a harmonised schedule for vaccines. The problem with that, though, is that you could have one for Europe and one for Africa, but they would be different. And we've already discussed in this conference the difference of age, biological age, immunocompetent age, and so on. All those differences and differences in nutrition and lifestyle and even culture might actually necessitate a change of vaccine schedule for that particular part of the world. We discussed that perhaps the WHO regional officers are a group that might be able to bring particular vaccine schedules to particular parts of the world. We need to identify groups and the vaccines needed for the elderly, but also compliance. Perhaps target vaccines themselves, for example, pertussis, have a campaign for that, or the pandemic 09 flu vaccine was also a targeted one. In some countries, measles is being targeted. But for that, there needs to be political will and vision, and it needs to be proactive rather than reactive. So we talked a little about a culture change for adult vaccination. For example, we have a successful paediatric vaccination campaign around the world. We're successful at targeting pregnant women. NGOs can play a role here as think tanks and provide correct information to various groups as they need it. Educating the young would be important because then they become older. So it's important to start young with this education. And as mentioned before, society is changing, so I think our views have to change about vaccination as a whole. There might be, and better communication, yes, we can educate, we can use the net, we can use social media, but we need, there's a lot of negative social media out there. We could institute a sensible blog rather than one that's not so sensible. Then you need to be competitive with that, otherwise the negative will simply take over. We also spoke about the problem of social isolation of the elderly being an issue. Sometimes they just get forgotten about. Some of the incentives, very briefly, we spoke about were incentives for GPs. There should be really no financial impediment to receiving a vaccine. WHO could be a key player in trying to get a harmonised schedule, whether it was regional or global. Gavi has a report out that for every dollar invested, there's $40 saved on hospitalisation and medical care. These kinds of economic facts and metrics need to be introduced into the community and, if possible, stratified for various age groups. Global policy should be an incentive for all. For example, we have age-friendly environment, we have healthy ageing campaigns. We need something similar that's friendly and global for a vaccine campaign. We need to keep records. We talked about informative vaccine books. They used to be a little bit old-fashioned, but it's something that families and parents like to have. They can keep a record of what vaccines their child has had and also themselves. We thought availability of vaccines through pharmacies was a good idea, but there might be differences in that. And also having vaccine campaigns in the workplace, in institutions and in nursing homes. So I'll stop there. Perhaps my colleagues would like to add.
Thank you very much. Before we leave, I would like to ask a question. It bridges already also a little bit for the next group. You know, there was this nice publication, WHO, last year in vaccines, with how WHO can liaise with industry. Because if we are really successful, what we hope, we will need a tremendous amount of more vaccines. So can you comment on that? Because I think this is an issue too, you know, at the production.
Absolutely crucial. One thing we've tried to do in the last year or two has been to make sure that industry is involved in WHO platforms and discussions, so they're involved at the beginning of these discussions. And I can talk particularly about pandemic flu, because that's an area I'm looking after, trying to get industry involved. Yeah. But there are other areas as well. We need to make sure that there's sustainable production of vaccines around the world for all the vaccines. And there's a big meeting on that, I believe, on about the 18th of June, on sustainability, and some people here will be aware of it. There's also a meeting on switching from seasonal to pandemic vaccine production and all the issues, public health issues and production issues involved in that in early June. So more and more, I think WHO is wanting to bring industry in as a full partner rather than someone at arm's length, and I think that's an important change.
Yeah, very important thing. Thanks for this addition too. So now, thank you very much. So we go to the next group. Now comes the pharmaceutical industry. Richard Aspinall and Antonio Cherubini. I don't know who will present. Antonio? Both of you. You start. Professor Antonio Cherubini di Ancona.
I would like to thank, of course, Stefania Maggi and Jean-Pierre Michel for the organization of the very interactive and lively meeting, and I think the session also represented very well the meeting. There were not many, but the discussion was lively, and I'm trying to summarize part of the points that are raised. First one is that how can we overcome the barrier to vaccine? And I think a very important topic we discussed was the need of evidence. It was raised in the past few days. We need good, solid evidence to support the efficacy, the safety, the cost-effectiveness of vaccines. And I think this is an extremely relevant point. When we come, particularly, nursing home have been mentioned before, and then we discovered that the vaccines have been tested in a population that is not the one of the nursing home. They are 85 years with dementia, multimorbidity, and they were not in the studies. So we believe that a very relevant step to overcome, also to convince public opinion, decision makers, people who pay that the vaccines are a good investment, is to start with a solid evidence. And in this respect, we had also to address a topic of pharmacovigilance, pharmacoepidemiology. Of course, we commented that it would be very important to have dedicated pre-planned studies in this area. We cannot rely really on spontaneous reporting. We need to have studies that are collecting data that we believe are relevant in these areas. The second point that we discussed was about, and it was mainly the pharmaceutical industry representatives that were raising this point, is the fact that there are probably in some areas, and Europe is an excellent example, too many points, too many decision points. Of course, there is European Union, but then the healthcare is devoted to the single countries. In each country, there are the regions. So when it comes to the implementation of the vaccine policies, this is a real challenge. In the United States, the situation is probably much easier, much simpler, and we should find a way, and it was already highlighted before, to simplify this decision chain in order, if we want to really implement vaccination in adult and older population. And I think Richard could start with integrate with the other, come in, Richard, with the other points that we discussed.
Thanks, Antonio. Yeah. Richard.
Thanks, Antonio. And I too would like to thank the organisers for inviting me to this Shangri-La of vaccine meeting. We talked about bottlenecks. Antonio's talked about two of them, evidence and decision profiles. My own areas that I'm going to talk about is the lack of an attitude towards prevention. So it's an idea that we have when we go to see the physician that he's going to treat us, he's going to give us some drug that will cure what we have. When we go and we get vaccinated by a physician, nothing happens. We don't get flu, but none of us have planned to get flu anyway. So how do we know that the thing is effective? It comes back to what Antonio was saying about evidence. And it was very nicely pointed out by a story about the physician to the Chinese emperor. The physician to the Chinese emperor only got paid when the Chinese emperor was well. He didn't get paid when the emperor was sick. We need to change our attitude towards how we think about prevention. Maybe our physicians need to get paid when we're well and not when we're sick as well. So we need evidence. We need evidence for outcomes, both for the elderly and for physicians. So that was one thing, the focus on prevention. The fourth point, was shortages. We talked about shortages in vaccines that are going to occur. They have occurred in the past because of a change in the business plan. We talked about a case where there were two manufacturers of PPV-23 and one pulled out of the market, leaving the burden of production on the other. And of course, shortages will follow. There are also likely to be shortages because of the intense need for a good quality assurance. If there's a problem with quality, the line goes down, your manufacturer doesn't produce the vaccine. So manufacturers have thought about plan B, what will they do in case of a shortage, and some of them think about stockpiling. But that doesn't work if you've got a short shelf life. So on this bit, we thought it's always difficult to deal with shortage, especially because no one wants to be vaccinated until you tell them there's actually no vaccine available. And then everybody wants to be vaccinated. And that's the thing. So
good point.
in shortages, it's unavoidable because of the complexity of the production process. It's problematic in terms of its management. And we thought it might require the provision of incentives from governments to manufacturers to help them. So the fifth point that we were dealing with, the fifth barrier, was potential for combination vaccines. So we were talking about these, and these are technically very difficult to produce and require long terms in their production. And it's not always a stable thing. So individuals go through thinking about combinations of vaccines with trivalent flu. And now, globally, we're thinking about changing trivalent flu to quadrivalent flu. So the whole process has got to be gone through again. So it's a technically very challenging thing to do. And we're not sure how much the market actually wants it. For example, if you think about, I'm going to travel, say, to Africa, or I'm going to travel to India, I need to go and get my flu shots. You don't expect to get a multiple vaccine. You expect to go and get vaccinated, but each with individual vaccines. And that's an expectation. So there may be no market driver from the elderly population for a combination vaccine. Anyway, thank you.
Thank you very much. So it could be a policy to say that the shortage of vaccines, all people would like to go, then all of a sudden, a miracle, the vaccine is there. Is that the... Yeah, no.
Yes, that's certainly a possibility.
Yeah, thank you very much. Right. So, good. So we switch now. We start, we first take media and science in adult vaccination because Professor Bernard Bailly has to leave a little bit earlier. But I think the presentation will be done by David Eaton. David, please come up. I think you have also a video to show. Yes, is that okay?
Towards the end, yeah.
Towards the end, yeah. He will help us, yes.
Can everybody hear me okay? Fantastic. My name's Dave Eaton. I'm Policy and Public Affairs Manager at the UK office of the International Longevity Centre. We're a think tank looking at solving the problem of ageing for governments. So we have different teams working on different policies like housing, infrastructure. I work in health and social care. And the first thing I tell any of our researchers when they arrive is it's no good you spending months working on a report if it's going to sit on a shelf gathering dust. If we're the only ones who read it, you've wasted your time. It's been great to hear every presentation so far has touched upon the need to communicate and to communicate better. So it really does underpin every element of the challenge to promote better uptakes of vaccines and life course approaches to vaccines. Now, our group had healthcare providers, industry, NGOs. We had a very good mix, very big group. We touched upon lots of different aspects of the media. And what came out of the discussion initially was that the media encompasses everything. Remember, media is anything that communicates a message. So when a Ministry of Health or a health authority sends the guidelines about vaccine routines to a GP, that's the use of media. And if that's not clear, you fail at the first stop. A poster in a GP or a hospital trying to urge people to get vaccinated and explain the merits of vaccines is media, as well as social media. So every time you post on Facebook, every tweet, again, an example of you communicating with your target audience, to more traditional forms like newspaper articles, radio and TV interviews. Now, when I hold a class at University College London for researchers about how to use the media, I normally say to them, why should we bother talking to the media at all? Normally the answer is, because I want more research funding, and if I get something in a newspaper, that's going to look really good to the research councils. Now, luckily, no one said that in our group. What we touched upon when we were looking at the barriers to vaccination the media can help address, we zeroed in on the fact that the media is both necessary, it's intrinsic in achieving our goals, but it can also be instrumental. We can also leverage it as part of a wider strategy to approach policymakers. So when it comes to overcoming myths with the public and overcoming vaccine hesitancy, again, it's intrinsic that we discuss these issues with the media, but we engage with all sorts of media, both social and traditional. When it comes to communicating with healthcare workers as well, it's an intrinsic element of our goal is to be able to communicate with them. But it's also instrumental. So people in our group also touched upon, as well as healthcare workers not being knowledgeable enough about vaccinations, not being committed enough or motivated enough to give them, and for patients to be able to seek them out. People also touched upon the fiscal restrictions that governments face. Now, here's where the media can be instrumental in achieving our goals. Coupled with health economic studies and the benefits, as the bottom line is always the cost benefit, you can also leverage your single greatest resource when it comes to dealing with policymakers, which is voters. If you can change the conversation, if you can put a narrative into the public domain which encourages people to put vaccination and preventative health on the political agenda, then you'll find it a lot easier to get into the front door of your ministries of health when it comes to presenting those studies that you've spent lots of time and money trying to produce. Now, we proposed two questions to our group to get the discussion going, which was, why is the media so bad at communicating information about vaccines? Why is it so negative? And why is social media so hostile? Now, I'm glad that very quickly a consensus emerged among the people in the workshop that those are sort of baseless questions. They're the wrong questions to be asking. Technology is never good or bad. It is inherently neutral. How we use technologies determines whether they're good or bad and whether they help us to achieve our outcomes. So in the media, We lamented the fact that media is sensationalist and that it gives the same amount of time and the same amount of airspace to anti-vaxxers with no facts, no evidence on their side, as it does to experts and professionals. But we're not going to change the way the media works. We have to learn to play the game and to be able to meet the challenge posed by anti-vaxxers. Now, someone in the workshop described anti-vaxxers as like soldiers. That's true, they're coordinated, they're organized. There are lots of different groups, but they communicate with each other and they have one unified message: vaccination's dangerous. If there's an adverse side effect, if there's a story, I guarantee you they will be calling round journalists the second it happens and saying, we're here for comment, we're ready to go on TV, we're ready to go on radio, here's a quote we've already prepared, here's some infographics and some images that you can use for your newspaper. They've given the journalist everything they need to make a story. How many people have issued a press release or called up a journalist after there's been an incident around vaccines? Okay, one person. 2 people have done that. We represent lots of different organizations here. Only 2 have contacted the media, but even again, if those 2 both contacted a journalist with a different message, with different facts or information, who does the journalist go to and listen to? So again, our group zeroed in on the need for us to be able to coordinate our activities. In each country, there are lots of different groups working around vaccines, but they need to be talking to each other, working together, so that they know if there's a story, they can say, okay, this one person is going to go and deal with the media. They're going to be able to offer their services, and they're going to have this one unified message. When it comes to social media, that came out of our discussion as well. How do you respond to anti-vaxxers? What's the message? Again, anti-vaxxers are coordinated. They have their message. It's very simple, it's very blunt, but it sticks in your head and it's effective. If we've learned anything over the past year, it's that the side with facts and the truth doesn't necessarily win. The side who have a very clear, emotive message, like take back control or make America great again, can end up winning. It's emotive, it's simple, it cuts through. So the need to coordinate our efforts and to have a single emotive message sort of came out of this. Now, before we start thinking about what that message is and how it can cut through, we have a video that was proposed by my co-chair Roberto Banabi, and I think our colleagues are going to play that video now.
Vivere a lungo è possibile, ma richiede impegno. Infatti non c'è vaccino contro il sovrappeso, il fumo, l'alcol, gli stravizi. Non c'è vaccino contro l'essere soli. Non c'è vaccino contro la mancata attività fisica. Non c'è vaccino contro l'assenza di curiosità e di voglia di vivere. Non c'è vaccino contro la tristezza. Arrivare a 100 anni e bene è difficile, devi impegnarti molto ogni giorno. Vaccinarsi invece è facile, immediato e non richiede sforzi. Grazie ai vaccini, i bambini sono protetti da malattie gravi. Grazie ai vaccini, gli anziani possono vivere in salute e meglio, perché un vaccino contro l'influenza c'è. Un vaccino contro la polmonite pneumococcica c'è. Un vaccino contro il fuoco di Sant'Antonio c'è. Vaccinati. Un'Italia in salute è una grande Italia.
Okay, now 2 things that came out of that video. Now, each country is going to have to decide which message is best going to resonate with their media. So you'll have to look at the policy landscape and decide what's going to resonate. So as an example, in the UK, our election at the moment, the ruling party has cut benefits for older people. They've cut back on the state pension, they've removed certain older age benefits. Our message might be around, are they also going to remove health provision for older people? If there's something that we've wanted out of vaccines, can we leverage that? But there are also universal messages that we can use across Europe and around the world, and they were demonstrated in that video. So you may have heard the voiceover said, grazie to each of the people, thank you. We know from basic behavioral sciences that when you thank people for a behavior, they're more likely to repeat it. Positive reinforcement works much better than warning people against something. This was tried in the UK on a tram network. When you thank people for buying a ticket, as opposed to warn them of the dangers of not buying one, they're more likely to buy a ticket. Similarly, when it comes to basic behavioral sciences, normally we're rational economic agents. We do things that are in our best interest. But when it comes to health outcomes, we only act if it's in someone else's interest. After the age of 55, the likelihood of having a major change in our health behaviors is normally because your partner's told you to, a grandchild might have prompted you to. In the UK, the fire service, if they want to have fire alarms installed in people's homes, they don't tell the parents. They go into primary schools and they tell the children, you need to tell your parents to install a fire alarm because you don't want mummy and daddy to get killed in a fire. Similarly, in New York, there was a campaign to increase the use of seatbelts in cars. It was a radio advert which had an 8-year-old girl's voice saying, Daddy, you haven't got your seatbelt on. In the video we saw as well, the focus was on the mother and the daughter. It's communicating the message that you're not getting vaccinated for yourself. We won't take a decision which is going to inconvenient us today, even if it means that we benefited from tomorrow. We will, however, do something if it's to benefit other people and if we're prompted to do so by other people. So I'd urge everyone, from our workshop, the conclusions were there needs to be better coordination towards other different groups so that we can communicate a single message proactively through the media. But think about that message. If you haven't read Sunstein's book, The Nudge, if you're not familiar with behavioral sciences and nudge economics, have a read, familiarize yourself, collate information on all the different groups within your countries, and coordinate, meet up regularly. Know what you're going to do when the next story breaks about vaccines and what message you're going to be able to communicate. Thank you.
So we come to the last presentation. It's the group about One Health and adult vaccines. It was chaired by Michael Davis and André Parodi. I think Professor André Parodi will present. Yeah. You both will present. Great. Yeah. Very interesting. I was in that group. I learned a lot.
Okay.
Yeah.
Thank you. We tried this morning in our group to answer 3 questions. The first question was, what are the contributions of veterinary and One Health approach in the control of human communicable diseases? Well, the veterinary medicine is very rich in both identification of infectious disease in animals and also control of these diseases. I would like to refer to an agreement signed in 2010 between WHO, OIE is Office International des Epizooties, that means the World Animal Health Organization, and FAO. In this agreement, the 3 authorities decided to share their experience in the control on emergence of new disease. Early detection, wide information, international sharing of information, implementation of sanitary rules, and also, 2 points, very important, budget, allowing to manage this policy, and also control of the communication. Control of the communication toward the farmers, toward the veterinary services, and also toward the media, because that is also an important issue. So veterinary medicine is able to give some example, not only on the control of emerging or emerging diseases in animals, but also of the cooperation which exists between human health organizations like WHO and animal health organizations like OIE. The second question was, what could be the role of veterinary medicine in increasing adult vaccination uptake? In this issue too, veterinary medicine is able first to give example of the emergence of new disease according, for example, to the climate warming. We know nowadays that the Lyme disease, the boreal disease, is expanding its territory. We know also that some new diseases are able to appear in our countries. For instance, 2 years ago, we have had spreading from Germany infectious disease in ruminant, Schmallenberg disease, and also that is related to the warming. We are also able to demonstrate the risk of introduction of some infectious disease in our country, in spite of the sanitary rule we have. Example, for instance, was done this morning by rabies. Every year, yes, we have in France, I knew this morning in Spain too, some cases of rabies, because people are traveling to Morocco, and then bring back some puppies infected with the rabies virus, and after that is a focus. So those experiences could be put in the knowledge of the human medicine authorities. We have also excellent example of the success of campaign of vaccination, both in companion animal. Canine distemper now does not exist in our country. Feline leukemia does not exist in our country, thanks to the vaccination. In large animal too, we have foot and mouth disease, for instance, a terrific disease, infectious in cattle, does not exist. So that are some examples able to be given to the human sanitary authorities in order to demonstrate the success of a vaccination. Of course, we have mandatory vaccination, but also non-mandatory vaccination. The third point is what are the impact of antibiotic use in animals in the increased antibiotic resistance in human. We commented yesterday how the large amount of antibiotic used both in human and veterinary medicine is pointed at a danger for emergence of antibiotic resistance. We have also good example of sanitary plan. I mentioned yesterday the French eco-antibio plan, 2012-2016, with both objectives. The first one is to reduce the consumption of antibiotic to 25%. Up to now, at the end of the first plan, the reduction is 20%. And the second, to protect, to don't use, in first step, some critical antibiotic like cephalosporin of 4 generations, to use before antibiogram, to use in animals non-antibiotic anti-infectious drugs, and also that could be a coalition between the three medicine, human medicine, veterinary medicine, and also dentistry. Dentistry is also involved in this plan. If we don't be aware for this problem, I said yesterday that some prediction nowadays say that in 2050, the first danger for human would be antibiotic resistance. Finally, we have considered that the One Health concept is not well known all around the world. In France, I am lucky, we are veterinary are very strongly involved in the cooperation between human and veterinary medicine. But I am traveling I am going to foreign countries. I am giving lectures, and I can constate that in some countries, people are very surprised to see that veterinarian could contribute to the management of the human health. And my personal proposal, it would be that we should include in the curriculum on our students in medicine, and perhaps both with veterinary students, I don't know, 1, 2, or 3 hours of courses, education, giving to these young people, future physicians, what is One Health, and how veterinary and human medicine could cooperate in the benefits of the human health. Thank you.
Thank you. Thank you very much.
Say a few words.
And now Michael Davis.
Yes, thanks. So I'm Mike Davis. I'm a veterinary clinician from the UK. I'd like to thank the organisers for having the vision to put the veterinary profession on the platform here, and I hope this will continue through other themes that you have. Vaccination, many of you who are medics in the room will not know actually what's going on in the area of veterinary vaccinations and how it already is impacting on human health. In rabies, for example, Cambridge University got involved with a project where they vaccinated the dogs that travel with the Maasai tribesmen in Africa, and they significantly reduced the amount of rabies in the tribespeople by doing that. You may not be aware of leptospirosis. Just quickly, leptospirosis is a waterborne spirochete, which is endemic in the UK. And for many years, we've been routinely vaccinating dogs against leptospirosis. About 10 years ago, we noticed that some new strains were emerging, and also the number of positive cases went from a few hundred to thousands in a very short space of time. And there now have been some new multivalent vaccines launched into UK to try to cover the new strains. But you probably don't know, but in Europe, the number of leptospirosis confirmed cases in humans doubled between 2013 and 2014. And at the same time, we've had an outbreak of leptospirosis in Cambridge. We don't know the numbers yet, but I know that the veterinary school was seeing 4 to 5 cases a week, and that was just one hospital in Cambridge. The public health authorities do not yet know how many human cases there have been, but what's happened in veterinary medicine is the same as in human medicine. The level of vaccinations has dropped over the recent years because of the anti-vaccine lobby, and as a result, a lot of those dogs are not vaccinated against lepto. So by having a large number of animals protected against lepto, they are an intermediate host for that disease. And if that level of protection is dropping, that is increasing risk for old people, because old dogs and old people are increasingly susceptible. So that just gives you one example of a re-emerging disease which is here all the time and is becoming more important. I just want to give you one example of an absolute perfect example of how One Health has worked. In southern Italy, leishmania is endemic, and there have been so many human cases that the human funding was put into developing a canine vaccine for leishmania, not to protect dogs that can also get leishmania, but to try to ring fence and put a barrier between dogs which are intermediate hosts and humans. So that's an example, a perfect example of where One Health can work. Because the problem we've got in veterinary medicine is the lack of numbers of pharmaceutical companies to develop new vaccines. And we have only literally less than a handful of manufacturers now who are prepared to invest. When we look at public health risks, we should be looking at it across the species, not just looking at one disease in one species. We should be looking at what's going to happen potentially, and we should not be reactive. As Manuel said yesterday, most of our examples we can quote you, apart from meat hygiene, which we're quite good at, are reactive to a pandemic or potential pandemic of something serious like Ebola. But we shouldn't be doing that. We should be taking a more proactive view. Last year, there were hundreds of new organisms identified as human health risks. 30 of them were zoonosis risks. So we should be planning ahead for how we're going to deal with particularly the hemorrhagic diseases and so on, and putting in place strategies. At the moment, there is no organization that does that. It's all within countries. There are collaborations, particularly on the food chain. But when you look at pet and horses, for example, and wildlife, there's very little coordination between veterinary and medical profession, and there does need to be something like that. Okay,
thank you very much also to you.